What if I told you that the food that you eat, the money that you make, and the roof over your head will determine if your life will be saved during the COVID-19 pandemic? And what if I told you that your race and your profession were simply not factors in that equation either? The COVID-19 pandemic brought to light the dangers of an environmentally influenced healthcare system, like the one we have in the United States of America. Environmental influences can have positive and negative effects on somebody's healthcare or health status. These positive and negative external environmental factors are known as the social determinants of health. The social determinants of health are influences on how you grow up, where you play, where you worship, the food you eat, the healthcare provider you see, the money that you make, and it influences the outcome of your health. Under the current structure of the U.S. healthcare system, patients with advantages in the social determinants of health, positive experiences with access to healthcare, access to adequate nutrition, access to education, higher wages, are considered to be in good health. Whereas patients with negative experiences with social determinants of health, that is lack of access to healthcare, lack of access to adequate nutrition, an improper education, and lower wages, exhibit poor health compared to advantaged patients. Majority of the healthcare inequities in the United States of America are attributed to these negative social determinants of health. These negative influences lead to a higher prevalence of chronic conditions and ultimately preventable deaths. In January 2020, coronavirus brought the world to a screeching halt. Family rooms became classrooms. Kitchens became home offices. A friendly smile was covered by a mask, and a friendly neighbor became a distant stranger. The Center of Disease Control and Prevention identified the most vulnerable population as those with pre-existing health conditions like asthma, diabetes, hypertension, and obesity, those who were immunocompromised, and those who are above the age of 65. In April 2020, we saw that the most vulnerable population was being redefined to include Black and Latinx communities. Since then, several outlets have reported that Black and Latinx populations have been disproportionately affected by the COVID-19 virus. As of August 18, 2020, the age-adjusted mortality rates are 3.6 times higher for Black communities and 3.2 times higher for Latinx communities compared to their white counterparts. This means that out of 100,000 Americans, 119 Black patients die, 106 Latinx patients die, and 33 white patients die of COVID-19. These disproportionate mortality rates seen amongst racial communities is believed to be caused by the negative social determinants of health seen in BIPOC communities. Currently, BIPOC communities experience less positive experiences with social determinants of health than the white community. For example, Black and Latinx community members have a higher prevalence of uninsurance rates compared to their white counterparts. Black and Latinx community members are also least likely to see a doctor due to monetary costs compared to their white counterpart. Negative environmental factors like limited access to healthcare, food insecurities, low-income wages, and crowded living spaces have increased the prevalence of preventable chronic conditions in BIPOC communities, like diabetes, hypertension, obesity, and asthma. These chronic conditions are the same chronic conditions that make a patient at higher risk for COVID-19. Just as the racial demographic information hit the media, so was the devastating news of the doctors having to make life or death decisions on who gets to live due to a medical ventilator supply shortage. The COVID-19 pandemic stressed hospital systems to the max, creating shortages in personal protective equipment, hospital personnel, medical ventilators, and ICU beds. This caused U.S. healthcare professionals, public health officials, government officials to take a good look at our medical ventilator triage protocol. In March 2020, the CDC said that 2.4 to 20 million Americans would need hospitalization during the COVID-19 pandemic. The hospital system in the United States of America estimated of owning about 62,000 fully functioning vents, and they also estimated owning about 98,000 basic ventilators that could work during a medical state of emergency. The CDC produced a study that said that we had about 12 to 13,000 ventilators in national stockpile. And then they estimated that we would need about 60,000 additional vents to make sure to be able to give proper treatment to those treated with COVID-19. Triage Protocol is used when there's a medical supply shortage. It's a system of sorting and allocation designed to maximize the amount of survivors with a limited amount of resources. Although triage protocols vary from hospital system to hospital system because they're determined by the hospital and on the state level, they all tend to have the same core values, allocation criteria, and the use of a triage team. Triage protocols are stated to be rooted in fairness and justice, with the following core values: transparency, duty to care, justice, and the duty to prevent unnecessary loss of life. The following are the typical criteria: age, need, usefulness, benefit, and these criteria vary from hospital system to hospital system. But the number one criteria is the score on an organ failing assessment. The priority of the sequential organ failure system makes an assessment based on the organ functionality of the patient, the number of chronic conditions, and the severity of those chronic conditions. The same chronic conditions that are identified as the major causes of the disproportionate effects in COVID-19 are the same chronic conditions that are accounted for in the organ failing system assessment. This means that certain chronic conditions like diabetes, hypertension, obesity, and asthma makes a patient more susceptible to COVID-19 and also obtain a lower organ failing score. But which communities have the highest prevalence of chronic conditions? And which communities have been identified as the most vulnerable population for COVID-19 virus? The Black and Indigenous people of color community. Yet, the only mention in the current medical triage protocol of race is a blanket statement that says race, gender, social status should not influence medical ventilator allocation. Well, there you have it. The protocol says don't discriminate. So we don't, right? No, that is not the case. The missing information in the triage protocol regarding the health inequities seen during the COVID-19 pandemic and the priority placed on the SOFA score infers that those identified as the most vulnerable population would be the least likely to receive a medical ventilator in a triage state. To test this theory, aka the most vulnerable, the least likely to get the medical ventilator triage, I conducted an exploratory comparative analysis between the current medical triage protocol and the well-established kidney allocation protocol. Kidney transplants, just as medical ventilators, are resource-dependent supplies, meaning there are not enough supplies to meet the demands of the patients. Simply in the US, there are not enough kidneys to meet the demands of the people who need a kidney replacement. And that's the same thing for medical ventilators. There are not enough medical ventilators in a state of triage to meet the demands of the patients who need them. Additional similarities amongst the protocols are the similarities in supply trends, which we'll see later, and we'll go over those data charts. The priority in the organ failing system. Now, the kidney allocation system has a different organ failing system, but some of the chronic conditions are the same. The chronic condition risk factors, the same reason why you're more susceptible to getting COVID-19, is also some of the same reasons why you're more susceptible to having kidney disease, which leads to needing a kidney transplant. And lastly, there are known and acknowledged disparities amongst the differences in racial communities on triage allocation recipients. So right here in this graph, we have the ventilator type versus the kidney transplant type. So this is where we see that similarity in supply trend. So for the ventilators, your feasible, which is represented by the blue, that is the basic ventilator. We have 98,000 of those in the US. Then the red would be the ideal ventilator. So there's about 62,000 of those in the US. And then the yellow is the total. So that's the total number of medical ventilators that we have in the US in the state of triage at the beginning of the COVID-19 pandemic. Whereas we shift over to the kidney transplants, right, that blue would be our feasible kidney transplant. And that red would be our ideal kidney transplant. That's the kidney transplant that works. Now, let me explain that a little further. So the reason why I say feasible is it's the one that works. Deceased kidney transplants are known to have more complications, medical complications and outcomes than the living kidney transplant. Living kidney transplants are the desirable kidney transplant that a patient wants, and it actually leads to better clinical outcomes and longer longevity of the kidney. So those are that red and that living kidney is the ideal one. So that is the similarity seen amongst the supply trends. So you can see that we have more of the feasible supply type and we have less of the ideal supply type. And that will come into play a little later why that is so significant. Although kidney transplant allocation protocols have stated that societal factors like race, gender, and socioeconomic status do not influence allocation decisions, racial disparities have been seen amongst transplant recipients. The U.S. Department of Health and Human Services has been reporting transplant demographic data since 1988. It is seen in the data that Black and Latinx communities receive fewer kidney transplants than white recipients, despite BIPOC communities having disproportionately higher burdens of kidney failure and kidney end disease. The recorded data exhibits that Black and Latinx communities receive fewer transplants than their white counterparts, despite BIPOC communities having disproportionately higher burdens of end-stage kidney disease or renal failure. This idea that BIPOC communities are least likely to receive a resource-dependent medical supply during a resource shortage is demonstrated in the kidney transplant demographic data. Researchers say that BIPOC communities face discrimination in every step of the transplant process, from the evaluation to the referral to the waitlist placement and actual receiving of the kidney transplant. Since 1988, there's been nearly 490,000 kidney transplants. Out of those 490,000 kidney transplants, Blacks have received about 24.3% of those kidneys. Hispanics have received about 14.1% of those kidneys. And their white counterpart patient has received about 54.8% of those kidneys, despite BIPOC communities having a higher prevalence and higher exposure to renal failure. Since 1988, there has been 322,950 deceased kidney transplants. Out of that big number, the Black population has received 29.7% of those deceased kidney transplants, whereas the Hispanic and Latinx population has received 14.5%, compared to their white counterpart at 48.3%. So you can already see that there is a trend in medical supplies where the white patient is receiving more kidney transplants despite BIPOC communities having a higher prevalence in kidney failure disease. The even more shocking disparity is seen amongst the living kidney transplant. Since 1988, there has been a total of 161,692 kidney transplants. Out of that number, the white patient population has received 67.7% of those living kidney transplants, whereas the Black population has received 13.5%. And the Latinx and Hispanic population has received 13.2% of those kidney transplants. When I brought to your attention the idea of noticing the supply trends, you will notice that there are less available ideal kidney transplants. And that follows the same pattern of the less available ideal medical ventilators. This racial disparity, this big gap seen between 67.7 and 13.5 and 13.2 leads me to believe that not only will Black and Latin patients face adversity to getting a medical supply during a shortage, but they also will experience additional roadblocks when trying to obtain that ideal medical supply. Due to the similarities seen amongst the supply trends in the feasible and ideal medical resources seen amongst medical ventilator triage protocol and kidney transplant allocation protocol, the priority in the organ failing assessment system, the same chronic risk conditions, and the demonstrated racial disparities seen in kidney transplant allocation, it can be deducted that the medical ventilator triage protocol, the current medical ventilator triage protocol, will show and demonstrate similar racial disparities, leading me to believe and conclude that under the current medical ventilator triage protocol for COVID-19, the most vulnerable population, the Black and Latinx population, will be the least likely to receive a medical ventilator during a medical supply shortage. Health equity is a patient's right to achieve their full health potential, regardless of their race, their social status, their economic status, and their gender. The current U.S. healthcare system, health equity is not a reality, and the COVID-19 pandemic brought this to light. Through gaps in medical ventilator triage protocol, we see that the most vulnerable population does not have equitable treatment when it comes to life or death. This is no surprise. BIPOC communities have been affected by healthcare inequalities for years, and the pandemic just shed a little light on that. And it goes back to understanding the negative influence that the U.S. healthcare system is structured on. Social determinants of health, like limited access to nutrition, limited access to healthcare professionals, limited access to education, low income wages, crowded living conditions. These all play an effect on a person's healthcare status, and that sadly determines whether they get to live or whether they get to die in a state of medical triage. This is a problem in America. People are dying. In my opinion, medical racism and the structural racism in the U.S. healthcare system that causes BIPOC communities to not have the access the health equity that they deserve is the biggest form of racism in this country, because it is life or death. Now you're probably asking yourself, how do we fix it? Well, the first thing is to look at policies like the medical ventilator triage protocol and realize that the medical ventilator triage protocol for COVID-19 was written for only a certain type of person to benefit from. There is implicit bias in that protocol. If you do not fit that perfect mold, you are not getting a medical ventilator. And that is inequitable. That is unjust. It is time for us healthcare providers, our officials in public health, our doctors, our lawyers, our government employees to look at protocol and realize the implicit bias in the protocol. Once we do that, once we recognize that social determinants of health determine life or death in America, and that life or death, because of the structural system, is determined on the color of your skin, there's going to be no change, and health inequity will continue. I see 3 solutions to this problem. The first is addressing implicit bias in the protocol. Writing a protocol that benefits not just one person, but several, that considers the social determinants of health, and that not every person's experience with healthcare is a perfect mold or fits into this perfect story. We need a more comprehensive view of a person's medical history before we can assess whether they get to live or whether they get to die in a medical shortage. Doctors and medical professionals, nurses, dentists, anybody in the medical field, we have to learn to address our implicit bias. Everybody has one. But without learning to address it, these situations, these health inequities will continue to happen, and the system, it will continue to be ingrained in the system, and we will never be able to combat this issue. Second, we have to, as a society, start to mitigate some of those negative structural racism qualities, those structural racism components, those social determinants of health, like lack of access to nutrition. To me, this is one of the most simple ways that healthcare inequities can begin to be mitigated. If a person has access to adequate nutrition, the prevalence in chronic condition begins to go down. That small change has a lasting effect, and we can see it in the protocol. Both in kidney transplant protocol and medical ventilator protocol, the thing that was considered the most was the prevalence of chronic conditions. Chronic conditions are preventable diseases that lead to preventable deaths. A small way to mitigate that is giving adequate nutrition to every person in America. Lastly, as a nation, we have to work to increase access to healthcare. The uninsurance rates, the people who do not see doctors due to monetary cost in BIPOC communities is ridiculous. Everybody should have access to see a doctor, to get a transplant, to get a medical ventilator, to go see a doctor before those medical conditions become a preventable chronic condition. By increasing access to healthcare providers, medical attention, medical resources, we can mitigate those negative influences of social determinants of health. Again, the most vulnerable population is the least likely to get help, to get a medical ventilator in a medical supply shortage under the current COVID-19 pandemic. This pandemic has taught us a lot of things, but the one thing that it's taught us the most, that there's inequities in the healthcare field, in the healthcare profession, in the U.S. healthcare system that need to be addressed. My name is Alexandria Masocco. I'm a senior at the University of Miami, and thank you for listening to my talk.